Mhm. Good afternoon, dear students. Now we'll start our lecture. This is the topic, rheumatoid arthritis. As usual, we'll start from definitions. It's a progressive systemic inflammatory disease. The etiology really is unknown. As much as written in the textbooks, in the consensus of recommendations, as less we really know about the etiology of many diseases, the rheumatoid arthritis also is such disease, such pathology. And the typical characteristics of rheumatoid arthritis are the symmetric synovitis with the development of joint erosions, multi-system extra-articular manifestations. What about epidemiology of rheumatoid arthritis? Approximately 1% of the total adult population is affected by rheumatoid arthritis, and the female to male ratio varies from 2 to 1 to 3 to 1. So the female population is more prone to the development of rheumatoid arthritis. And from 40 to 60% with advanced rheumatoid arthritis will survive 5 years or less following diagnosis and die 10 to 15 years earlier than expected. So we know uh, very different pathologies which may lead to rheumatoid arthritis, but in reality, we know not so much. So we can suspect some infectious agents like bacteria, different type of bacteria, including mycoplasma, mycobacteria, enterobacteria, viruses, HTLV, retrovirus, herpes virus, Epstein-Barr virus, rubella, parvovirus, and probably may play a role the defective recognition of autoantigen. So sometimes we see that pregnancy induces remission, and this remission is linked to maternal fetal human leukocytes antigen mismatch. And with the genetical testing, we can see the strong association with complex human leukocyte antigen on chromosome 6HLA-DR4. You see here the rather sophisticated schema of pathogenesis of rheumatoid arthritis. It's the possible sequence of events with network of cells, cytokines, and mediators. And at this point, we simply take into account such many interactions between many factors, humoral, cell, and so on. Then, rheumatoid factor. Its most common autoantibody in rheumatoid arthritis. It binds to the Fc portion of immunoglobulin G molecule and usually an immunoglobulin M antibody. And we detect it in approximately 70 to 80% of rheumatoid arthritis patients. And the high titer predicts adverse outcome with development of erosive arthritis and vasculitis. So, what is the hallmark? It's the synovitis characterized by hypertrophy and hyperplasia of the synovial cells and subsynovial stroma. And inflammatory cells infiltrate the synovial lining. And microvascular endothelial injury is the principal abnormality. You see here in this schema how the rheumatoid arthritis pathology develops with the thickened synovial membrane, with the deposition of synovial fluid and degraded cartilage. Now let's discuss the diagnostic criteria for rheumatoid arthritis. The first is morning stiffness with the duration exceeding 1 hour. Then swelling of 3 or more joints. The third, swelling of hand joints, proximal interphalangeal, metacarpophalangeal, or wrist. The fourth, symmetric joint swelling. By the way, criteria from 1 to 4 must have been present continuously for 6 weeks or longer and must be observed by a physician. Then, subcutaneous nodulus, not so steady factor, serum rheumatoid factor, and the seventh sign, it's the radiographic evidence of erosions or periarticular osteopenia in hand or wrist. And a diagnosis of rheumatoid arthritis requires that 4 of the 7 criteria are fulfilled. Clinical feature and diagnosis. Synovitis, or in other words, joint inflammation. Onset is usually insidious from weeks to months and unrelenting. 15% may be acute within a few days. The earlier clinical features include morning stiffness, joint tenderness, and swelling with restricted range of motion. The next progressive clinical features include joint deformity and dysfunction from tendon and ligament inflammation, so-called ulnar deviation, the deformity of the thumb, swan neck and boutonniere deformities of the interphalangeal joints, then low-grade fever, and at last subcutaneous nodules of extensor area. Look, usually it is enough to take a look at the patient hands to understand that it's the rheumatoid arthritis. We see here the so-called ulnar deviation to ulnar bone of the fingers with wasting of the small muscles of the hands and synovial swelling at the wrist. The extensor tendon sheath and the metacarpal phalangeal and proximal interphalangeal joints. The next one, we name it like swan neck deformity of the fingers. What is the boutonniere? Boutonniere, it's the French language definition of such type of deformity, resembling while the patient holds something in his with his fingers. And swan neck deformity, look how it looks. The same swan neck deformity of the fingers. The next, rheumatoid nodulus and olecranon bursitis, and the nodulus were palpable within as well as outside the bursa. The next, we simply repeat these main features. Joint involvement is typically symmetrical, with the metacarpophalangeal, wrist, proximal interphalangeal, metatarsophalangeal joints, shoulder, knee, ankle, and elbow joints. You see, in order of decreasing frequency of involvement. So, the first place, take metacarpophalangeal joints, wrist, small wrist joints, proximal interphalangeal, metatarsophalangeal. The big joints are involved in less frequency. Then, cervical spine involvement may lead to Atlanta axial subluxation. Fortunately, this complication we meet very rare. Radiographic features. It's the very important approach, and we can reveal bony erosion, cartilage loss, juxta-articular osteopenia, soft tissue swelling. And using the MRI, we can reveal Atlanta axial subluxation. You see here the American Rheumatology Association criteria for assessing functional status of rheumatoid arthritis. Class 1, when the patient has a complete ability to perform usual daily activities, for example, self-care, vocational, avocational. Class 2, ability to perform usual self-care and vocational activities with limited avocational activities. Class 3, ability to perform usual self-care activities, limited vocational or vocational activities. And at last, class 4, limited ability to perform usual self-care, vocational or vocational activities. And you see here the typical lesions associated with the rheumatoid arthritis. Wrist joints, you simply are not able to differentiate these small joints. Then you see the typical lesions of proximal interphalangeal joints like this, like this, like this, like this. The same you see the typical erosions of the proximal interphalangeal joints, distal not so typical, but it's more typical. Metatarsophalangeal joints with the presence of erosions. You see here the ruptured Baker cyst in rheumatoid arthritis, and this arthrogram showing radiopaque contrast medium in popliteal cyst and tissues of the calf. Here you see the involvement of Atlanta axial joint. And here is the subluxation of cervical spine, flexion and extension. Sure, such complicated cause of rheumatoid arthritis may at last lead to tetraparesis. Fortunately, we meet this problem very rare. The next, extra-articular manifestations of rheumatoid arthritis. Systemic manifestations like fever, weight loss, fatigue, susceptibility to infection. Then, musculoskeletal, muscle wasting, tendinosynovitis, bursitis, osteoporosis. Hematological, with anemia, thrombosis, eosinophilia. Lymphatic, with splenomegaly, so-called Felty syndrome, very active type of rheumatoid arthritis. Then involvement of nodules with in sinuses, fistula, ocular complications, manifestations with episcleritis, scleritis, scleromelar cell, keratoconjunctivitis sicca. So dry keratoconjunctivitis. Vasculitis with involvement of digital arteries, ulcers, pyoderma gangrenosum, mononephritis, multiplex visceral arteritis. Cardiac manifestations, I'd like to say not so frequent, with pericarditis, myocarditis, endocarditis, conduction defects, coronary vasculitis, granulomatous aortitis. Pulmonary manifestations, including appearance of nodules, pleural effusions, fibrosing alveolitis, bronchiolitis, and so-called Kaplan syndrome associated with occupational pathology. Neurological, with cervical cord compression neuropathies, peripheral neuropathy, mononephritis multiplex, and at last amyloidosis, which involves at first the kidneys. Differential diagnosis. We have to distinguish rheumatoid arthritis with osteoarthritis, not so difficult, but spondyloarthritis. Spondyloarthritis in some cases may resemble the clinics of rheumatoid arthritis, but remember that spondyloarthritis practically only the male population is ill with this disease. Then gout and pseudogout, so-called chronic fatigue syndrome, fibromyalgia, then polymyalgia rheumatica, giant cell arteritis. In some cases, some features of systemic lupus erythematosus may look like symptomatics of rheumatoid arthritis. And at last, infectious arthritis. What are the goals of therapy? Our task is to control disease activity, alleviate pain, maintain function for essential daily activities, maximize quality of life, and slow progression and rate of joint damage. Very popular are non-steroidal anti-inflammatory drugs. At first, cyclooxygenase 2 inhibitors like nimesulide, meloxicam, celecoxib. These drugs have the improved gastrointestinal tolerability, reduced effects on renal blood flow, and no effect on platelet function. The treatment modalities for rheumatoid arthritis include the usage of NSAIDs, steroids with the restricted application. Then DMARDs. What are the DMARDs? Disease-modifying anti-rheumatoid drugs. Then immunosuppressive therapy, biological therapies, and at last surgery. What are the advantages of disease-modifying anti-rheumatic drugs? So these drugs slow disease progression, improve functional disability, decrease pain, interfere with inflammatory processes, and retard the development of joint erosions. These are the traditional DMARDs. These traditional DMARDs include leflunomide, methotrexate, and sulfasalazine. Leflunomide, the treatment include the loading dosage of 100 milligram for 3 days with the supportive dosage of 20 milligram quite a day. The duration is from 4 to 8 weeks. Methotrexate. The dosage varies from 7.5 to 20 milligram per week, once a week. Duration from 1 to 3 months. And at last, not so effective sulfasalazine. The duration varies from 1 to 3 months. The dosage from 0.5 to 3 grams per day. The more effective is the combination DMARDs therapy. This regimen does not increase toxicity levels, long-term outcome more favorable, and superior efficacy to single DMARD regimen. And the possible combinations include methotrexate, sulfasalazine, hydroxychloroquine, another cyclosporine methotrexate, and at last leflunomide methotrexate. Glucocorticoids, very popular treatment, but we must remember that glucocorticoids should be used as a bridge therapy until DMARDs become effective. Local injection is efficacious and less toxic than DMARDs. And low-dose systemic therapy may slow the rate of joint damage and is effective in refractory rheumatoid arthritis, but we must remember that as less is the usage of glucocorticoids, the best long-term prognosis we expect. New drugs therapy. Such an approach with radiation synovectomy with isotopes and immunotherapy, which includes anti-CD4 monoclonal antibodies, anti-tumor necrosis factor alpha antibodies, and anti-interleukin-2 drugs. And these biological drugs now are used. They have the application for treatment of rheumatoid arthritis, rather expensive but perspective. So, anti-tumor necrosis factor alpha medications. These are etanercept, the most popular infliximab, and some other medications like adalimumab, certolizumab, golimumab. And these drugs decoy receptor for TNF-alpha and another, including infliximab. These are the antibodies to tumor necrosis factor, and infliximab must be given in combination with methotrexate. Then, anti-B cell therapy. It's rituximab. And this treatment should be preceded by methylprednisolone, 100 mg intravenously, chlorpheniramine, 10 mg intravenously, and paracetamol given 30 minutes prior to each infusion. Then, inhibitor of T cell activation, abatacept. It has favorable safety profile. Another medication, anti-interleukin-6 drug, tocilizumab. It looks like more effective than anti-TNF in methotrexate intolerant patients. And at last, anti-interleukin-1, anakinra. Anakinra was reported like less effective than other biological drugs. Surgical therapy. It may be considered to prevent damage to joints or tendons by inflammatory synovium, to correct structural joint damage resulting in discomfort and limitation of function, most useful for upper extremity, tenosynovectomy for exuberant nodal formation or synovitis in extensor tendons, and joint fusion or joint replacement, not so widespread approach. The next, non-pharmacological management. It includes rest, exercise like flexibility stretching, muscle conditioning, cardiovascular aerobic exercises, sure diet, weight control, the most difficult problem for our patients, and at last, physical occupational therapy. What about the prognosis? Progressive course of disease in two-thirds of patients resulting in disabling and destructive disease. 20 patients may have mild and intermittent course. 10 patients, 10% of the patients may achieve complete remission. What are the factors predicting poor prognosis? Male, gender, age above 50, poor functional capacity, positive rheumatoid factor, presence of nodules, and human leukocytes antigen, therefore haplotype. 3 to 10 years decrease in survival in 50 or 50% of patients. What are the causes of premature death? Cardiovascular complication, malignancy. Remember, the patient for a long time use immunosuppressive drugs. Infection or sepsis, vasculitis, rheumatoid lung, and gastrointestinal hemorrhage and perforation. Sure, depending on the usage of NSAIDs. You see here the new treatment paradigm. On the base of this pyramid, you see usage of salicylate, non-salicylate salicylate, non-bind other NSAIDs, with the usage of patient education, physical therapy, occupational, orthopedic, surgery, simple analgesics, intra-articular steroids, high dose steroids for flares or extra-articular disease. And on the apex of this pyramid, we see the usage. The old MARS like leflunomide, methotrexate, then azathioprine, biologic response, modify some other immunosuppressive drugs, including dipyrethylcilamine, cyclosporine, and at last new experimental agents and procedures. But instead of such efforts, unfortunately, our facilities are not so effective in the long-term treatment of rheumatoid arthritis, unfortunately, in our days. But we can achieve some possible remission of the cause of this disease. Now we move to systemic lupus erythematosus. It's a chronic inflammatory autoimmune disorder which may affect many organ systems, including the skin, joints, and internal organs. And the disease may be mild or severe and life-threatening. You see here the systemic features of this disease with butterfly rash, very typical, Raynaud phenomenon, arthritis, lupus nephritis, and not so frequent heart problems and pleural effusion. Systemic lupus erythematosus frequently affects women, with the ratio female to male as 9:1. And the prevalence is higher in African Asian countries. In European countries, it is lesser. The most common age at onset is young age, from 15 to 40. And the deposition of immune complexes is believed to explain many of the clinical features. Etiology. Genetic risk, complement deficiencies, FCR mutations, autoreactive B cells and T cells, autoantibodies may be pathogens. And the best disposal hypothesis of lupus etiology, inability to clear apoptotic cells, leads to occurrence of neoantigens and formation of pathogenic autoantibodies. What is the symptomatics? It's profound fatigue, rashes, joint pains. Immune system may attack and damage several organs such as kidney, brain, or lung. Symptoms and damage from the disease can be controlled with available anti-inflammatory medications. If a patient is not closely monitoring, the side effects from the medications can be quite serious. Now we consider the American Rheumatism Association criteria for systemic lupus erythematosus. First, malar rash. It looks like fixed erythema, flat or raised, sparing the nasolabial folds. It's the most typical feature of visible feature of the systemic lupus erythematosus. Then, discoid rash. It looks like erythematosus raised patches with adherent keratotic scarring and follicular plaquing. Photosensitivity looks like skin rash as a result of unusual reaction to sunlight. The next, oral ulcers. Oral or nasopharyngeal ulceration may be painless. The next, arthritis, non-erosive, involving two or more peripheral joints. Serositis, pleuritis, convincing history of pleuritic pain, rub or pleural effusion, or pericarditis, with pericardial rub, ECG evidence or effusion on ultrasound or X-ray examination. Renal disorder, with persistent proteinuria exceeding 0.5 gram per day, or presence of cellular cast, red cells, granular or tubular. The next, neurological disorder, with seizures or psychosis in the absence of offending drugs or metabolic derangement. The next, hematological disorder, including hemolytic anemia, or leukopenia or lymphopenia, thrombocytopenia in the absence of offending drugs. Immunology disorder with the appearance of anti-DNA antibodies in abnormal titer, presence of antibody to SM antigen, or positive antiphospholipid antibodies. And at last, anti-nuclear antibody disorder with the abnormal titer of anti-nuclear antibody by immunofluorescence. And for the purpose of identifying patients for clinical studies, a person must have SLE if any 4 of 11 features are present serially or simultaneously. So such approach is useful for some, maybe more scientific than clinical purposes. 4 out of 11 signs. But in reality, we can recognize disease with not so significant efforts. Look here. It's the typical pattern of malar rash, How looks the increased photosensitivity? Discoid lupus with scarring alopecia is not so frequent problem, but the butterfly malar rash sparing the nasolabial folds is the most visible feature of the systemic lupus erythematosus. Discoid lupus. Usually the dermatologists meet this problem. You see here the lesions of the chest. It shows the typical rounded appearance of discoid lupus, and the whitish appearance is caused by scaling, and two dark spots are biopsy sites and are not part of the disease. Okay. Discoid rash. You see here red raised patches with scales. The porous hair follicles may be plugged. Scarring often occurs in older lesions, and the majority, approximately 90% of individuals with discoid lupus have only skin involvement as compared to more generalized involvement in systemic lupus erythematosus. So-called livida reticularis in systemic lupus erythematosus is the consequence of involvement of peripheral arterioles. The next, articular manifestations of systemic lupus erythematosus. Synovitis and so-called Jacob arthropathy. Sometimes such changes resemble the rheumatoid arthritis lesions. And here you see the avascular necrosis of the hip. Very bad, very significant complication of the systemic lupus erythematosus. It also may be supported and induced by the usage of high doses of glucocorticoids. The next, serositis. It may look like pericardial involvement here, vasculitis with peripheral necrosis of the tips of the fingers, pulmonary manifestations. In only the very high activity of the disease with pleurisy, acute pneumonitis, acute reversible hypoxemia, chronic pneumonitis, pulmonary hypertension, so-called shrinking lung, isolated diffusing capacity impairment. Cardiac manifestations with pericardial involvement, inflammation and diffusions, myocardial involvement, acute or chronic, and endocardial involvement with the development of Liebman-Sachs endocarditis, diffuse valvular thickening, and premature development of the coronary artery disease, so the accelerated progression of atherosclerosis is also the feature of systemic lupus erythematosus. The next, lupus nephritis. Lupus nephritis may be considered like a key symptom of the systemic lupus erythematosus because it really defines the long-term prognosis of the disease. You can meet on biopsy normal glomerular membrane, but immunoglobulins or complement may have deposits. Mesangial lupus nephritis we also can meet. Mild focal glomerulonephritis, but the most frequent problem is the diffuse proliferative glomerulonephritis. Less rare is membranous glomerulonephritis and interstitial and tubular nephritis. It's this view. It shows the deposition of immunocomplexes on glomerular-based membrane. What are the clinical presentation of lupus nephritis? These are hypertension with new onset, peripheral edema with weight gain, renal insufficiency or failure with elevated creatinine level, asymptomatic urinary findings like proteinuria, uh, erythrocytes, less commonly leukocytes in the urine sediment, and casts, erythrocyte, red blood cells, cast aminos. Organic brain syndromes in systemic lupus erythematosus with psychosis, seizures, cognitive decline. Blood results in systemic lupus erythematosus with low level of hemoglobin. Also, the hemolysis may play a role. The leukocytes level is low, anti-nuclear antibody positive, anti-DNA positive, anti-ENA often positive. The complement 3 and 4 low, and the elevated titer of immunoglobulins. How to treat? The symptomatic treatment includes analgesics, NSAIDs, and the good advice to avoid the sun insolation and avoid vaccination. Vaccinations are contraindicated. Moreover, sometimes vaccination may induce the SLE development. It is possible to use hydroxychloroquine when the systemic lupus erythematosus includes only skin and joints involvement. And for complete clinical picture, we use immunosuppressive treatment with the usage of azathioprine, prednisone, cyclophosphamide, and drugs are dedicated for major organ involvement like lupus nephritis, vasculitis, and involvement of central nervous system, and careful assessment and treatment of cardiovascular risk. What about the future therapies? Targeted monoclonal antibodies may be considered, anti-B cell therapies like rituximab, cytokine manipulations, and at last, bone marrow transplant, not so frequent approach. So it's a joke. We show this slide on offline lecture, how we show our parents and how it looks in reality. So I would like to advise you, take care, and thank you for attention. Goodbye. If you have some questions, I can ask. I can answer, not you may ask. Okay?